Yep. Hello, I'm Troy Morrison. I'm a orthopedic surgeon in Bolivar at CMH. I've been there for about 11 and a half years now. And I do orthopedic surgery, pretty much most everything in orthopedics, but I have a fellowship in spine surgery, so I concentrate on spine, do a lot of total joints and a lot of sports and a lot of everything. And that's I think a little bit of a rarity now because most everybody gets super specialized. There's not very many people like me that do more than just spine. Most everybody has their little niche and they don't get outside that niche. But I like to treat patients. That's why I became a physician. So I don't want to just treat one thing and then never see them again, which is very easy in orthopedics because if you have arthritis in your spine, you have arthritis somewhere else too. So I get to see patients over and over again, operate on their back, operate on their knees, their hips, their shoulders, develop good relationships with them and their family. So one of the lost arts of medicine is touching the patient. You guys are mostly third years, I think. Yeah. So you will see, you will be on, probably have already and will in the future be on rotations where you treat the patient based on the chart, not the patient. So that's one of my main teaching points when you rotate with me is a good physical examination, especially with what I do. Most of the time patients hurt in areas where it can be a lot of different things. And the number one thing I use to determine what I do is the physical exam, not the x-rays, the MRI, or the CTs. So then that's what we're going to talk about today. We're going to go over some physical exam findings and just a few pearls that will guide us in our ability to diagnose and treat our patients. Your power to provide care, I believe, is in your physical exam, and you get your physical exam builds your differential diagnosis. If you don't know what you're looking for, you won't find it. So you just can't have the radiologist tell you what you're looking for based on their read. So the power to help people is really in your differential diagnosis. We get very, very narrow-minded, especially now that we're so subspecialized that we really don't treat our patients very well. I don't have any disclosures pertaining to physical exam. So after this presentation, I'd like all of you to have a real good understanding of who you're trying to be or who you want to be as a physician and what that looks like and what your job really is. I want you to be familiar with physical exam as it pertains to orthopedic patients and maintain a real broad differential diagnosis. So a little bit about me. I grew up near West Plains, Missouri, about an hour and a half east of here. I went to Drury University in Springfield, went to KCU in Kansas City. I did my residency in Youngstown, Ohio for orthopedics, and then I did a fellowship at Texas Back Institute in Dallas. And now I work at CMH. So that's who I am. Who are you? And what is your job as a physician? So interesting, I never really looked up the definition of a physician before until I made this slide, and it's very interesting. It's a healthcare professional who has earned a medical degree and is clinically experienced and is licensed to practice medicine. That's it. Ask your patients what a physician is. I'm sure they'll tell you something completely different. So our responsibilities are three things, and that's it. And they are in order of importance. Number one, our most important job is to get the right diagnosis. Number two, our job is to develop a prognosis for the patient. And then the least important thing we do is treat the patient. Because if we don't have the right diagnosis, it doesn't matter what we do. Because if you only have one diagnosis for knee pain, Everything, if that's arthritis, then everything will look like arthritis. I see that a lot, even with orthopedic surgeons. When we see a patient, we almost always get imaging studies to develop a differential diagnosis, but that's the wrong way to do it. First, we want to examine the patient to know what studies to get. Because just because somebody comes in with hip pain doesn't mean it's their hip. If you ask a patient where their hip is, you'll get a different answer every time. So first we diagnose. We have to start with a good broad differential diagnosis. Then we prognose. What is prognosis? It's educating and involving the patient in their care and using shared decision-making to determine what treatment options to pursue. We empower the patient to make an informed decision and set appropriate expectations. That's our number two job. And then the least important thing we do is treat, because we must treat the cause of the pain in orthopedics, basically, the cause of the symptoms for the treatment to be effective. So the more tools we have in our toolbox, the better we'll be able to treat our patients. So how do we get a good differential diagnosis? Number one, we listen to the patient. If you listen long enough, which none of us do, even me, especially me, they will tell you what's wrong. Second thing, you do a good, thorough physical examination. And if you're not comfortable touching patients, then you need to get comfortable or do pathology or radiology. I hear it a lot from patients who have been treated elsewhere or got an opinion elsewhere. And the most common thing I hear, a dissatisfier from patients who have been seen elsewhere, is the doctor never touched me. That was weird for me in the beginning because I felt a little uncomfortable, like touching people. But to hear patients over and over again, that was their complaint, made me a whole lot more comfortable just doing a physical exam and being comfortable touching them. So either get over it or don't work with patients. So I'm going to go through a few complaints and show you a few pearls, something that you guys should be able to use in your rotations coming up. Wrist pain is a very, very common complaint, right? You could have wrist pain for a whole lot of different reasons. So what's the differential diagnosis for wrist pain? Well, it's very, very broad, right? And that's how we want to start, very, very broad. So number one, how do we get a differential diagnosis? We listen to the patient. So we ask them the appropriate questions. Where's it hurt? What's it like? What makes it better? What makes it worse? This is a good example of something you will see. Maybe you've already seen it and you just didn't know it, but the patient's complaining of pain. They point right to that spot. They say they have pain worse with gripping things or holding things. Does anybody have an idea what might be right there that would cause pain? No. Okay. So what do we need to do after they tell us it hurts right here? Examine them, right? Anybody have any idea what they would want to examine first? So that is pain, and they will show you right over the first dorsal compartment. First thing I do when a patient tells me they have pain right there is I have them do this test, the Finkelstein test. And it's just like this. Have them grab their thumb, and you can have them do it or you do it, but you just ulnar deviate the wrist. If that reproduces the pain right along the tendons, then you have a real good idea what the diagnosis is. Radiologist is not going to give you that diagnosis, especially now. We're all third-year medical students, right? How to be politically correct. It's a lot more common to have nurse practitioners and PAs cover walk-ins Patients really like walk-ins. They come in, and I can tell you the vast majority of the time when a nurse practitioner or PA calls me, they give me the read from the x-ray. That's all they have. They don't get this. They don't get your education. They definitely don't get a residency. So this is a real good example of a very, very simple, quick diagnosis that you're not going to get any other way except touching the patient. So that's de Quervain's tenosynovitis. Treatment's very, very simple, just like any tenosynovitis. Anti-inflammatory medications, stretching, injections, rest, give it time. So another patient comes in with wrist pain. We ask them those same questions, right? Where does it hurt? What's it like? How did it start? What makes it better? What makes it worse? This patient has burning pain, tingling at night and while driving, loss of sensation to the fingertips, dropping things, pain radiates up the arm. Anybody want to ask me any questions like I was the patient? You want to know anything else? Is there a laser on here? Thank you. 99% of the time, the patient's going to say yes, all of them. Literally, and I think Liam knows that. I think we saw a couple like that. My whole hand, that's what they will say most of the time. So you really got to dig in. You got to touch them. Does it numb here? Is it numb here? They're not going to give you the distribution you're looking for unless you really pull it out of them. One of the things I say is, where does it start? On the thumb side or the pinky side? Or what's worse, the thumb side or the pinky side? Because they're convinced it's the whole thing. Might be the whole thing, but usually it's not. So if they say it's worse or starts on the thumb and index finger and middle finger, worse at night, worse with driving, what comes to your mind? Carpal tunnel syndrome, right? But you can't get too narrow-minded yet, because there's a lot of things that can do that. So on exam, what are you going to find? Carpal tunnel is easy. You guys know carpal tunnel. Come on. What are you going to find? Yeah, not always, but you definitely want to know if there is, because that's part of prognosis. What else? Yes. Where's the numbness going to be? Say it's classic textbook carpal tunnel. Where's the numbness going to be? Okay. What about the palm? Not the palm. That's a very big pearl that everyone seems to forget, because this branch right here, that's the palmar cutaneous branch of the median nerve. Point to the right one. Yep. Palmar cutaneous branch of the median nerve comes off proximal to the carpal tunnel the vast majority of the time. So carpal tunnel does not affect sensation to the palm. So if they do have numbness, true numbness in the palm, then I would broaden my differential diagnosis for sure. So Fainlein's test and Tinel's test. So you got that right. How do you do Tinel's? You tap slow, tap gentle, tap fast. What causes carpal tunnel? I mean, like, does typing cause carpal tunnel? No. We know for sure typing does not cause carpal tunnel. So those little wrist things that you have everywhere are worthless. What does is vibratory tools. like a chainsaw or like weed eating, something that vibrates in your hands. That is something that causes carpal tunnel. So in my mind, I try and reproduce that when I do Tinels. So I'm going to hit it hard and hit it fast. Try and light them up a little bit. That way you know for sure if they're being honest or not. So you do Tinels right over the carpal tunnel, tap it hard and tap it fast. What about Phalene's test? Yeah. Phalene's test is flexion, right? You're trying to decrease the space in the canal to reproduce the symptoms. This is not how you want to do it because you don't have any control over how hard the patient is pushing, and they're not going to do that. 90 degrees of flexion at both wrists, you're just not going to see that. So you have to do it. And that's one of the first things I do if I'm suspecting carpal tunnel is I'll do Phalene's first for a couple of reasons. One, it's a little bit weird if you're staring into somebody's eyes holding their wrists flexed for 60 or 90 seconds. So I can do that while I'm asking all those questions. Then it's not so weird. And it also makes Tinels, I think, a little bit better because it's already a little bit irritated if they do have carpal tunnel. So I think it just increases the sensitivity. So elbow pain, we're going down the arm a little bit. Same thing, we got to keep a broad differential diagnosis in the beginning. We got to get a good history. Where's the pain? What's it like? Where the pain, I mean, sounds like a silly question, but where is your pain is crucial. So this dude holding a tennis racket has pain over the lateral elbow with activity. So we think of lateral epicondylitis, right? So if they point right to the lateral epicondyle, which you should be able to palpate, it has there, shoot. So the provocative test for lateral epicondylitis is, Cohen's test or pain at the lateral epicondyle with resisted extension of the wrist, right? Very simple. Or if they don't have pain when you do that, then it's probably not lateral epicondylitis. And you should have the elbow extended when you do that. So you have another patient that comes in right after this patient. Same history. Pain right there with activity. Now what's your differential? What else? Is that the same spot? Pretty darn close. So you do your Cohen's test and it's negative. So then what do? You try some other tests, right? So also where the pain is crucial, especially in small areas like fingers and elbows and areas where there's a lot of different anatomic structures. Elbow is one of them. So if they have maximal tenderness 3 to 5 centimeters distal to the lateral epicondyle, that's not the lateral epicondyle, even though it's close. And that's why the exam test matters so much. So you do Cohen's test and it's negative. So then what do? You do resistance against supination with the elbow and the wrist extended. And if that causes pain, you should have something else move to the top of your differential. So radial tunnel syndrome is not very common, but I think it sees us more than we see it. The crucial thing to remember is where the pain is, and there's no motor or sensory dysfunction. So you're not going to get numbness. You're not going to get weakness. You're just going to get pain. And why is that? Because the superficial cutaneous branch comes off before it gets pinched, right? And that supination test is the provocative test for radial tunnel. So there's the difference. It hurts here or it hurts here. So you got to pay attention. There's a lot of things right there in the lateral elbow. And actually, it's pretty easy to palpate. So when you do examine an elbow, be very precise where it hurts, especially in kids. That's one of the hardest things to figure out is pediatric elbow, because they don't give you really good answers. And that's another example where x-rays don't help very much. So let's move up to the shoulder. This patient has achy pain at night, complains that they can't sleep, they can't find a comfortable position to sleep in. They have sharp pain with reaching, pulling, and pushing. There's a lot of things across your shoulder, right? Everything that goes into your arm. So you really should have a very broad differential diagnosis for shoulder pain. Because it could be neck, it could be something in the shoulder, it could be something further down. There's a whole lot of tests for a shoulder for that reason. This is a whole nother lecture. But these are some of the tests for impingement syndrome, Neer's test, Hawkins test, again for impingement syndrome, drop arm test for impingement rotator cuff tear. You want to do a good exam testing the rotator cuff muscles. All comes down to anatomy. What does each muscle do and how do you test it, right? Abduction, internal rotation, external rotation. When you do an exam, you want to test each one of those muscles, the 4 rotator cuff muscles individually. That way you have a real good idea. Torn rotator cuff, those 2 muscles, the most commonly torn 2, supraspinatus and infraspinatus. That's abduction and external rotation, right? So if they have weakness, then it's a tear. If they have pain, then but no weakness, then it's probably not. Okay. Another guy comes in with burning pain at night, can't sleep, achy pain with activity, just like the other one, radiating into the hand. And they have periscapular pain. Have you guys got to examine very many patients yet? Thoracic back pain is kind of a tough thing because everybody has it. It's very difficult to diagnose what's going on. And most people don't know this. This chart right here. Pain along the medial border of the scapula is very commonly radicular pain from C5, C6, C7, and C8. Any of those 4. We don't commonly think of that as radicular pain. I get a lot of patients sent to me that their primary care provider or physician orders a thoracic MRI for thoracic back pain. And it shows nothing because they almost never do show anything. But had they known that that's a common radicular pattern, they probably should have done a better physical examination and got an MRI of the neck instead of the back. Very big dissatisfier for patients. Number 1, they got to pay for it. Number 2, it takes forever to get. Number 3, it takes forever to get to see me for me to say that we got to go get an MRI of the right spot instead of the wrong spot. So, cervical radiculopathy. Key exam in all of spine, exam is key. It trumps everything, including MRIs and CTs. Exam tells us what's wrong and what we should do about it. MRI just tells us what's wrong. So you should have this memorized. You have to know all the myotomes and all the dermatomes. And you should test them every time. We don't have to go through the whole thing, but it is something you should know, especially brush up on it before primary care rotation, orthopedic rotation, spine rotation. You should know all of that and have it all memorized before that rotation. It can be difficult. There's a lot of things on those 2 charts, right? There's a lot. Really, it's not. They're just numbers. Numbers and areas. And it's just anatomy. The key to doing a good neurologic exam is to be consistent and do it the same way every time. Because if you do it the same way every time, you won't miss something, and it's easy to dictate too. So my sequence is always do reflexes first, because patients get very, very confused when you start telling them to push and to pull, and they get very confused. And then when you're trying to do reflexes, then they're jerking against you and it's not working out. So I always do the reflexes first. That way they stay relaxed. Then I do sensory exam because I'm not asking them to move anything. Then I do special tests like Hoffman's. And then I do the motor last. There's a deep tendon reflex grades. The key to remember about the grading is symmetry. You want to know because you want to know if it's getting worse or getting better, but everybody has different reflexes. Just because somebody has a 4 out of 4 everywhere doesn't mean they're myelopathic. That just may be them. But you want to note that so that you know next time if it's different. And you also want to note symmetry. Symmetry is more important than the level. This is one of the keys. I showed you a shoulder exam earlier. This patient would say they can't sleep at night unless they put their arm up above their head just like that. Anybody know what that means? This is crucial. Because then you can narrow your differential really quickly with this. You know it's not a shoulder problem. Because how many people who have shoulder pain like to do that? None of them. Only people with cervical radiculopathy like to. And they will tell you, I can only sleep if I have my hand up under my pillow or behind my head. You wouldn't know that unless you asked them, right? Lhermitte sign is a special test too. It's for cervical radiculopathy. Yeah, flex their head forward all the way, look down. If that causes radicular symptoms down the arms, that's consistent with cervical radiculopathy. Sperling's test, you should all know that. You basically have them turn their head and side bend one direction and push down on their neck. I honestly don't do that one too often just because I already have a good idea if it's gonna be radiculopathy or not based on my exam prior to that. And it's just not as reliable. But you should still do it. So that's neck pain. What about back pain? Back pain is the #1 reason why people go to the doctor, not anything else. Back pain. 6 million people, $50 billion a year. So if you know this flow chart, you can figure it out, treat them, and take care of them. Looks very complex, but really it's not. You just got to start in the right direction. So causes of back pain. There's a study, 2009, that showed that only 65% of back pain actually comes from the back. That's 2/3. So 1/3 of the time it's coming from something else or a combination. So like I mentioned, there's a lot of different causes of back pain. There's the list. You got to figure it out. How do you figure it out? Well, you start with a very, very broad differential diagnosis like that whole list. And then you also do a good thorough physical exam. There's another study. These are patients who already had a lumbar fusion that said it didn't help me. And then you got to figure out, okay, then the first guy got it wrong. I got to get it right. So where's the pain coming from? And 43% of the time it's coming from the SI joint. So our #1 job is to diagnose the cause of the pain, because that does happen a lot. People will operate on a hip and it's really their back, or their back and it's really their hip. And there's lots of examples of that. So speaking of hip, where's your hip? It's something I never ask patients because I don't want to hear what they say. But you ask them where it hurts. This is their hip sometimes. 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 So you have to narrow it down to exactly where it hurts and have a broad differential diagnosis. Hip pain for me, I come in with very open-minded every single time, even though I already looked at an x-ray. Because just because you have arthritis somewhere doesn't mean that's what's causing their problem. So here's a reason why hip pain is so hard to diagnose, because that's a lot of stuff. That's a lot of stuff that can cause a lot of problems. The back, the hip, nerves, tendons, muscles, bursa, all those things can cause hip pain. And the SI joint. 30% of the time, people who present with back pain is really coming from their sacroiliac joint. So how do we figure that out? This is a very interesting, I really like this picture, because when you show somebody that referral pattern for pain, they're going to say what? Sciatica. It's okay for patients to say sciatica. It's not okay for you guys to say sciatica. That's a layman's term, and you're not a layman. It's radiculopathy, not sciatica pain. But in this case, it's not. It looks a lot like radicular pattern, right? But it's not. It's a referral pattern from the SI joint. There's another example. So you show somebody that, and they're thinking, oh yeah, you got a pinched nerve. But you might not. 30% of the time you don't. So SI joint history is key, especially in going down that flow chart that I showed you earlier. What makes it worse and what makes it better? SI joint pain. Have you guys studied SI joint pain yet? A little bit, probably, maybe. SI joint pain hurts worse with sitting. Back pain doesn't. Acetogenic pain, discogenic pain, it's not worse with sitting, but SI joint pain is. One of my favorite questions to ask when I'm thinking of SI joint pain is, does it hurt when you drive in your car from here to Springfield? So that's from Bolivar to Springfield. They say yes, and then I'm going down that road. I'm going to tailor my examination for that. There's a lady, a person putting their foot out the window because it hurts to sit. They have night pain, pain at night. That's not discogenic back pain. Discogenic back pain hurts when you're loading your disc. So it's not, you're not going to have pain at night from discogenic pain. Where does it hurt? Remember I said that was crucial. It's crucial here too. There's something called the Fortin finger sign, and that's what I do every time for back pain. Point with one finger where it hurts. They point to the PSIS. I have them do it again. They point to their PSIS the second time, then that's a positive Fortin finger sign. That's not their hip, that's their SI joint, or could be. But especially with the SI joint, you need more than one positive test. You need 3 positive tests. And there's several provocative tests that I'll breeze through here. One's the Faber's test, that's Patrick's test. Everyone here should know that. Flexion, abduction, external rotation. You can do it with them sitting down or lying down. I tend to do it with them sitting, but either way is fine. So basically, all these provocative tests are stressing the SI joint. So the SI compression test, you're compressing across the SI joint. You have to compress across both of them, but that's how you do it. Thigh thrust, you're trying to put a shear force across the SI joint, so anterior to posterior. So you have them flex up their knee and kind of, and that's literally what I do. I think about the anatomy and trying to shear that SI joint. Distraction test, you're trying to gap it open. So you're pushing on the anterior pelvis and trying to really stress that SI joint. Gelson's test, you're doing a rotational moment of pressure across the SI joint. So you're trying to rotate that joint and flare it up. So the 2 most sensitive and specific are Patrick's test and the posterior shear of the thigh thrust, where you're trying to put a shear stress across that joint. And this study was done, it was validated with a validation of the provocative test, and basically they used the SI joint block to confirm that. A lot of people don't realize your SI joint is the largest joint in your axial skeleton. It's like 3 times bigger than a disc. A lot of potential to cause pain. It moves in all 3 directions. There's only 4 degrees of sagittal rotation and 2 millimeters of translation. It doesn't move much, but as you all know, it does move. There's a lot of risk factors for SI joint pain, like this poor lady, leg length discrepancy, gait abnormality, a limp, prolonged vigorous exercise. That doesn't narrow down for me, but it might for you. Scoliosis, spinal fusion to the sacrum, definitely. You get adjacent segment degeneration above or below. That's below, obviously. Pregnancy. I see a lot of ladies who, if you ask them, they'll say their pain started when they were pregnant. They usually won't volunteer that. There are a lot of spondyloarthropathies. How am I doing on time? Spondyloarthropathies that affect the spine. The number one people think about is ankylosing spondylitis. There's not 100% in medicine. This is one of the very few 100%. 100% of people with ankylosing spondylitis will get sacroiliitis. We used to ignore the SI joint because we didn't have a good fix. Now we do. We have a great fix. It's a minimally invasive fix for those patients who need it. They get up and walk and go home the same day after an SI joint fusion. So what about discogenic back pain, or back pain actually from the back? There's a lot of things in your back. There's facet joints, discs, ligaments, muscles. Facet joints are the probably most forgotten thing and probably the most common cause of back pain, in my opinion. Behind every disc, there's 2 facet joints, one on the right, one on the left side. In between the disc and the facet joint is the exiting nerve root. So even with facetogenic pain, you can get radiculitis, not radiculopathy, but radiculitis. When patients tell me their back goes out and they're on the couch for a week or 2, it's almost never a disc herniation. It's very commonly their facet joints. And there's a really good, easy fix, not permanent fix, but fix for facetogenic back pain, and that's a rhizotomy or radiofrequency ablation of the medial branch. When they truly have facet joint pain, this works very, very well. What about hip pain? Symptoms of osteoarthritis. There's one question, and Liam knows it. I love to ask patients with hip pain. It's, do you have trouble putting your shoe and sock on? Why do I love that question? What do you have to do to put your shoe and sock on? What are you doing right now? Yeah, flexion and external rotation. You gotta get your foot way up there, right? If it's coming from your back, I can move your hip all day long. It's not gonna bother your pain. But if I can't get your foot up there, then you have loss of range of motion and reproduce pain with motion of the hip. That's probably gonna tell me your pain generator is your hip, not your back. Here's a good x-ray of arthritis of hip. It shows a normal hip. You've got good joint space, not really a lot of sclerosis, nice round femoral head. This side you don't. Just because you have this doesn't mean that's the cause of the pain. That's why you do a physical exam, move their hip and see if it hurts. You can have a bad looking x-ray, but not pain. So radiculopathy, lumbar radiculopathy. Just like the chart of the upper extremity, you got to know all the myotomes and dermatomes of the lower extremity too. And really it makes sense if you think about it, but really you just got to memorize it. So reflexes again, reflexes you want to assess symmetry, not just grade. you want to evaluate for clonus and Babinski's. Does anybody know how to evaluate for clonus? No? See how much time I have. Neurogenic claudication. Does anybody know what that is? It says it right there. Claudication is pain with walking, right? Neurogenic claudication is pain with walking caused by pinched nerves, right? There's vascular claudication too. Neurogenic claudication, the key to remember about that is they will have a normal neurologic exam. You sit and examine them, nerves are going to all be intact most of the time, vast majority of the time. Just because they have an intact neuro exam doesn't mean they don't have severe stenosis. In that case, central stenosis. Anybody know what myelopathy is? No? Good guess. Good guess. No. It's what? Injury to, not disease of. Myelopathy is pinched spinal cord, basically. Where does your spinal cord end? Anybody know? L1. Close. You're the closest one, so you get all the points. L1. So you can't have myelopathy from stenosis below L1 unless they have a tethered cord. So that's something to remember. This is also a diagnosis that everybody misses. I can't tell you how many times patients get tossed around to the point where they're in a wheelchair because they can't walk and no one can figure it out. They can't figure it out because they don't hurt. Pinched spinal cord does not cause pain. I mean, literally, I can probably give you 10 names right now of people that came into my office after 6 months of being in a wheelchair because no one can figure it out. Easy fix too. We get them walking. Easy fix. So myelopathy is spinal cord compression. It's caused by severe central stenosis. You get upper motor neuron signs. Anybody know what those are? Yeah, hyperreflexia, not hyporeflexia. Radiculopathy causes hyporeflexia, asymmetric. So hyperreflexia. What else? Bulbocavernosus reflex. Probably not going to do that in the office unless you're real aggressive. Babinski, yes. Clonus, whoops. Clonus and Hoffman's. Use it. Yep. Clonus. Does anybody know what clonus is? I know Liam does. Yeah, of your ankle. So you basically forcefully dorsiflex the ankle and hold pressure on it. And their foot will bounce up and down. If it keeps bouncing up and down, that's sustained clonus. You want to count the beats. Sometimes there'll be 1 or 2 beats or 3 or 4 beats or sustained, but you want to document that because the next time you read, you want to know if it's worse or not. But the key to the diagnosis of myelopathy is your physical exam, not the history. Acute cauda-equina syndrome. That's one of the very, very few emergencies that we deal with. Anybody know what that is? Yes. Yes, there is. Very good. So I mentioned the spinal cord ends at L1. Then what happens? Yeah, the cauda-equina, or Latin for horse's tail. So there's a lot more accommodation or room in the lumbar spine for stenosis because they can kind of move out of the way. Well, cauda-equina is caused by acute event like a disc herniation that causes acute stenosis, central stenosis that pinches all of them. If that happens, then you get signs and symptoms, low back pain, numbness, weakness. You get those radicular symptoms and and severe pain and incontinence. What kind of incontinence? Can't guess. What are the other types of incontinence besides neurogenic? Stress incontinence, urge incontinence, neurogenic incontinence. I get that question all the time because people freak out when someone has severe back pain or leg pain and they say, "Do you have any trouble peeing?" Yes. Well, is that because they just didn't make it in time? Usually. But you got to ask the right questions. Can you feel yourself having to pee? If they say yes, I just can't get there in time, then that's urge incontinence. If they pee because they stood up and they had a sharp stabbing pain in their back, then that's stress incontinence. If they get up from a chair and walk across the room and look back and the chair has a puddle of urine in it and they didn't know it, that's neurogenic incontinence. And that's caused by overflow incontinence. Same thing with bowel incontinence. They don't know they have to go. They poop their pants and didn't even know it. If you poop your pants, you're going to know it, unless you have caught aquina. So, it's crucial because I get that question all the time. People call and freak out and say, my patient has incontinence. I sent them to the ER. Okay, what kind of incontinence? They can't tell me. So most common cause is acute central stenosis, most commonly to be acute. It's a disc herniation. You get a large central disc herniation, and to be caught aquina, it's got to be significant. You should have the diagnosis before you get the MRI. The MRI is just telling you where it is. So how do you do that? You get an MRI. You can't get an MRI. You got to get a CT myelogram. You could do a post-void residual. You scan their bladder and see how full it is. Most of the time, I can see a full bladder on the MRI. Someone has a giant bladder on the MRI with a giant disc herniation. That's making cauda equina. So you also need to do a good, thorough physical exam, neurologic exam, if they're weak, if they're numb. There's only really one definitive way to diagnose cauda equina syndrome, both clinically and legally. There's only one. Anybody know what that is? Yes. You got to stick your finger up their butt and check their sphincter tone. If you don't do that, and a patient later on has cauda equina, you don't have any evidence that they did not have cauda equina when you saw them. So it's yes, Your Honor, I did a digital rectal exam and documented it. I work, one of the guys that trained me, he was an expert witness all over the country, and he said, the only thing that matters legally is that. So if you suspect it, you got to check it. So I went through a lot of different things. One of the things that a lot of primary care docs and nurse practitioners and PAs ask me is, who do I send this patient to? Who do they need to go to? When it's something that involves the hip and the back, or could be hip, or could be back, or could be both, there are a few of us that are trained in both of those things, hip pathology and spine pathology, and that's orthopedic. A fellowship trained orthopedic spine surgeon like me. There's not very many in this community. Actually, there's none in Springfield. There's one guy in Joplin and me, and that's it. So if you don't feel like your patient got the right diagnosis, send them to someone else. Because I do see that a lot. I see a lot of fusions for hip arthritis because they didn't do a good thorough exam. So remember, diagnosis is key. You have to get the right diagnosis. Develop a sequence that works. Like I mentioned, a neuro exam, you do it the same way every time. And it becomes very quick, very efficient to dictate. So just when you're on rotation, do that. Watch them do it, ask them how they do it, develop your sequence, which what makes sense to you and works with you, and then do it the same way every time. And then you don't need to follow a big chart like this because you already did a good thorough exam. So just because of particular diagnosis, just because you have not seen a particular diagnosis doesn't mean it hasn't seen you. Always remember that. Do you guys see it in there? Anybody see it? You guys need to be better diagnosticians. Nobody? Huh? Yeah, patient's coding, and only one person saved it. Like a snake in the grass. Any questions for me? That's kind of meant to be a quick overview and a few pearls. There's just too much to go over to be 1 hour, but I also wanted to illustrate the importance of a physical exam. So, any questions? Okay. Thank you. Person on the chat says, I see multiple patients with SI joint pain every week, and I have a high success rate Should I stop seeing them? Oh, for OMM? Huh? I don't know what the question is. Not sure what the question is, but if you are having good success diagnosing and treating, then keep doing it, obviously. I just realized the camera's probably too low. Okay.